Welcome to our series on geographic atrophy. This companion podcast resource is supported by educational grants from Apellis Pharmaceuticals, Astellas, and Topcon Healthcare. In this episode, two retinal specialists walk through a real-world case of geographic atrophy, highlighting both the natural history of GA and the impact of newly available treatments on patient outcomes.
Today, we're going to talk through a real-world case from a patient my colleague treated for geographic atrophy. This is a patient who has been seen at follow-up visits for over a decade, providing a great opportunity to discuss the importance of imaging for monitoring disease progression. And her journey really shows how our options for GA have changed since she first came in back in 2011.
And this is a great case study because when she first came in, there really weren't any treatments available for GA. Now things look very different.
So let me start from the beginning. In 2011, she was 68 and came in with vision loss in her right eye. That turned out to be wet AMD, and we treated with an anti-VEGF. Her acuity stabilized around 2100 in that eye, so the left eye became her better seeing eye. And it looks like she had some risk factors that we see all the time: former smoker, bad family history, intermediate AMD in the left eye. At that point, the best advice would have been to take AREDS2 vitamins and to continue not smoking.
Exactly. Over the next several years, she held steady, but by 2019, things had changed. She developed multifocal non-central GA in the nasal macula of that left eye. Still about 20/32 vision, but she started noticing scotomas.
And that's an important teaching point. Even when the fovea is spared, patients can still have trouble with day-to-day functions like reading and driving. We know from the AREDS2 study that most non-central lesions eventually progress directly into the fovea.
That's right. So around then, I offered for her to participate in a clinical trial. She was nervous because this was her better seeing eye and she'd already lost vision in the other eye from wet AMD. The thought of triggering CNV in her good eye really scared her.
And that's understandable. Clinical trials for these complement inhibitors, the GATHER trial for avacincaptad pegol, or ACP, and the OAKS and DERBY trials for pegcetacoplan, did show an increased risk of new neovascular AMD. It's not huge, but it's real. And patients who have lived through wet AMD are especially sensitive to that risk.
Exactly. She ended up declining to participate in the trial, but by 2021, she was getting more symptomatic and was worried about being able to keep driving. Then in 2024, things lined up. The treatments were FDA approved, and her symptoms were worse. That's when she decided to start ACP.
And at that point, her acuity was still around 20/40, right?
Yep, we started monthly injections, and after a year, she was holding at 20/32. The imaging showed slowed progression compared to before.
That lines up well with the trial data. ACP slowed GA growth by 14% to almost 30%, with the effect really becoming more pronounced in the second year. And pegcetacoplan, the C3 inhibitor, showed about a 16% to 22% reduction in lesion growth over 2 years.
Right. We're not reversing atrophy, but we are buying meaningful time. For someone in her 80s who still wants to drive and stay independent, that's a big win.
So let's talk about imaging for a second. How are you following her and monitoring the progression of her disease?
We do OCT at every single visit. That's my standard for GA patients, looking for progression, but also for any sign of CNV. If I forget to order it, I'll send them back.
Same here. And you can use other imaging tools. Fundus autofluorescence is great for tracking lesion area, and near-infrared reflectance can be really helpful in clinic when you don't have FAF.
Exactly. In her case, those tools helped us show her the changes over time, which really reinforced the decision to start treatment.
And practically speaking, she was already used to injections from her wet AMD. So unlike many of our patients, that part wasn't a barrier.
Exactly. And that definitely made the conversation easier.
For injection-naive patients, the injection itself is often the scariest part. But for her, the bigger concern was the risk of CNV in her good eye.
And that's where counseling matters. We can reassure patients that even if CNV develops, it can be treated with an anti-VEGF alongside GA therapy.
Yes, and in these patients receiving multiple injections, I'll try to do same-day injections when possible, wet in one eye, dry in the other. Otherwise, it's too hard on patients and too hard on the clinic.
Agreed. So, to wrap up this discussion, this case shows how a patient's GA progressed over more than a decade and how the arrival of complement inhibitors has really changed our management strategy, allowing our patients to preserve their vision in ways they couldn't in the past.
Yes, and this case highlights some key points for optimal GA management: early detection, consistent imaging, patient education, and timely initiation of therapy when appropriate.
Exactly. And most importantly, we can finally offer our patients something to slow down this disease. For people who've been waiting years, that's a huge shift.
Thank you for joining us for this patient case discussion. This patient's journey illustrates how far the field has come in managing geographic atrophy, moving from supportive care alone to disease-modifying therapies that can preserve vision and independence. To read through this case and earn CE credit, you can follow the link in the description to helio.com, where you will find this case presented as an Ace the Case activity, along with a variety of additional CME programs. Also, please check out the other podcast in this series, which discusses risk factors for developing geographic atrophy and the impact of recently approved therapies on patient outcomes.